So the advent of the DAA really changed the playing field in the liver transplant setting. Decompensated Hep C is rapidly becoming less problematic. Many patients are stabilizing or improving their liver function, although HCC continues to be problematic for this group of individuals and for others. What we're facing here, and I think transplanters everywhere, is that NASH is quickly becoming a major issue. Patients have appreciable concurrent cardiovascular morbidity, and this complicates their care both pre and post liver transplantation. 15 to 20% of waitlisted patients still succumb before they can get transplanted, although I must say that this number has decreased somewhat with the new allocation system in the United States. However, this really underestimates the true morbidity and mortality in cirrhotic patients. When we review our M&M cases bi-monthly, I would say 75% of our patients who die are not actually on the waiting list yet. So this cirrhosis and its morbidity continues to be a major problem both in the US and worldwide. Our populations are aging, so thus there's an increased liver disease burden. Here, patients with HIV are coming to transplant more frequently. As you may know, patients who have HIV, their most common cause of demise is liver disease and not opportunistic infection. So this was the, again, the playing field in the United States up to 2019. The country was split into 11 different geographic regions that were basically arbitrarily set up 30 years previously, and there were a lot of inequities with the system. There were 58 OPOs, which are local organ procurement organizations that their performance translated into successful procurements for patients. And here in New York, you could see that there were a total of 5 different OPOs in New York State. And centers in New York State, whether it was in the University of Rochester or in the city, were competing for donor organs for their patients. So in May 2019, we had a new system that came into place. So organs were not geographically based the same way, which were state-based, but organs that became available to recipients that were listed within 250 nautical miles of the transplant hospital. And this is termed the acuity circles distribution model. This came into effect in early 2020. Prior to that, the MMAT was adopted in an effort to try to balance the playing field with regard MELD scores. So for instance, in New York State, prior to this, you would get transplanted if your MELD score was in the 30s. Lower than that, it was unlikely you were going to get transplanted unless you had an extended donor. You would go to other parts of the country and you could get transplanted with a MELD score in the low 20s. So these systems were adopted to try to, again, even the playing field. As you can see, this is the number of transplants that have been done in the United States since 1990. And there has been an increase in the overall number of transplants. This is probably not related to these new systems that have been adopted, but rather related to the really tragic epidemic of opioid overdose deaths that we have here. In the United States, it was greater than 100,000 last year. So that probably contributed to the overall increased number of transplants. However, I think that I'll show data at the end of the talk. I think the sicker patients are getting transplanted, and this is translating into lower deaths on the waiting list. The other thing that went into effect is a national review board for appeals, so that if we have patients who do not meet standard criteria for variances, they're sicker than their MELD score. This used to be done on a regional basis, and there was a lot of subjectivity and variable opinions in approving or disproving these patients. This is now done on a national basis. So with the new system that came into effect, a lot of the variances remain the same. So patients who have decompensated Wilson's disease get status 1 criteria, same as fulminant liver failure. People who have HCC, similar 6-month waiting period before they gain enough priority. These are non-standard exceptions. So these are diagnoses that may be approved if patients' cases are referred to the regional review board. And you can see they vary from repeated episodes of cholangitis, polycystic liver disease. There are some criteria that are set up for this. For instance, people who have multiple episodes of cholangitis must be in the ICU, must have 2 episodes of documented bacteremia within a finite period of time. There are non-standard exceptions for patients, say, who have refractory ascites, chronic rejection post-transplant. A very common one is failed TIPS. So these are no longer standard exceptions. So these have to be vetted on a case-by-case basis by the National Review Board. Prior to this, if you had HCC, you had the MELD elevator, which meant that if you had stable disease, every 6 months you would get more points and you would be capped at 34. Now you're capped at 28. So again, to try to even the playing field. The only problem with this, however, is that there's a logjam of patients at 28. At our center, I think we have 45 or 50 patients who have MELD scores of 28 who have HCC. So the MMAT is a way of standardizing the MELD score in regions. So what this is that UNOS looks at all patients who were transplanted in the region, short of fulminant liver failure, pediatric patients, and patients who have MELD appeals, and they get a median MELD score at which these patients were transplanted, and they subtract 3. And that's what, say, your HCC diagnosis, when you have the HCC diagnosis, what your MELD score is. So for instance, in New York, the median MELD score has been 31. So minus 3, 28. So patients who have HCC have a MELD score of 28. The same with patients who have cholangiocarcinoma and these other diagnoses, hepatopulmonary syndrome, portal pulmonary hypertension. These are reassessed every 6 months. So 6 months ago, we were 27. Now we're 28. For us and for our patients, it's good because prior to this, you needed a lot higher of a MELD score to get transplanted. So what are some of the more recent changes in UNOS that are taking effect? Well, because of the explosion of patients undergoing liver transplantation for alcoholic hepatitis, they're trying to standardize these diagnoses. So the diagnosis of alcohol cirrhosis will become alcohol-associated cirrhosis without alcohol hepatitis, and then there's going to be a separate diagnosis of acute alcoholic hepatitis. Prior to this, it was it fell under the moniker of alcohol-related cirrhosis. As we all know, though, this standardization is not going to be great because many patients who have acute alcoholic hepatitis also have cirrhosis. So I think this is the first step in trying to codify these diagnoses a little bit better, to give us a little bit information on the patients that we're transplanting these days with alcohol-related liver disease. So since the 6 month rule and the circles rule, the acuity circles went into effect, it's now been 18 months. What has changed? And I thought it would be important to show you this, especially those who are abroad, to see what we've gone through and how our system has transitioned. So since the circles paradigm went into effect, the deceased donor liver transplants have increased by 5% since policy implementation. There were also almost 100 more simultaneous liver kidney transplants. So this is a major issue in the US. Many large programs, upwards of 15 to 20% of all liver transplants are combined liver kidney. And this is, again, in large part due to the sick alcohol-related liver disease patients that we're transplanting, and those who have NASH. So transplant rates increase significantly for patients who have higher MELD scores. This is what we wanted. This is what the new system was designed to do. The great majority of liver transplant programs have experienced similar or higher transplant volumes after the policy change. This was a concern amongst smaller programs that their numbers would go down and their patients would not have adequate access to transplant. However, this does seem not to have been the case, and that there is some fairness overall. Large programs, obviously, who have sicker patients are going to benefit more. So 2 years ago, our program did 130 transplants. The following year, we did 170 transplants. And for us, this has translated into a significant decrease in the number of patients that we have dying on the waiting list. It was intended in the policy, geographic variability has decreased at the levels of the donation service area, state, and region. Again, this is what we wanted to accomplish with the new system. Not unexpectedly, the median distance between the donor hospital and transplant hospital has increased. More transplants are being performed at distances between 250 and 500 nautical miles between the hospitals. Importantly, the median cold ischemic time increased very modestly, which is important and something that the surgeons were always concerned about. So I think everyone on this call is aware of indications for transplant referral. I put this up because I think that I found that over the years, it's really important to refer patients early to a liver transplant center. I don't think liver transplant centers are ever upset when patients are referred too early. When they're referred a little bit on the late side, I think it's more of an issue. You know, some of the things I would really point out here are patients who start developing sarcopenia. I think that this is a rapid downhill spiral in terms of them becoming frail. There's a lot of interest in this these days, and clearly I think that this is an underappreciated factor for our cirrhotic patients. So if you start having some muscle wasting in patients, even if their MELD is low, I would refer these patients in. We have patients who have very low MELD scores. However, they have platelet counts of 20,000. And I think these are individuals that have appreciable portal hypertension. They're going to have a fatal complication. So referring them early, I think, is prudent. And the presence of hyponatremia over the last decade has really become an important milestone in the natural history of people who have cirrhosis, recognized as an important milestone. We encourage everyone, gastroenterologists, docs in the community, to refer stable cirrhotic patients for liver transplant. Why is this? Well, we all know there's a lot of people on this call who have an interest in acute and chronic liver failure. There's a very high mortality, and we see this all of the time. Patients are stable and then they develop infections, they develop gallstone disease, they decompensate, they develop we're seeing a lot of this in New York with COVID. So what we tell our patients that, you know, you're stable now, we'll follow you in the transplant system, but if something happens to you, sometimes out of our control, outside of having chronic liver disease, your liver disease may worsen and you're going to need a transplant more rapidly. We all know that the true renal function is grossly underestimated in cirrhotics. This is more of an issue in women, and something to be highlighted with the issue of disparities in liver disease and in liver transplant. This is something that we're all starting to recognize as a major issue. So referring these patients, even if they have minor GFR aberrations, I think is important. Another thing we're starting to understand is that repeated episodes of encephalopathy have acute and chronic sequelae. Post-transplant, we have a lot of patients who say I'm having difficulty with my memory. In the past, we chalked it up to, well, it's related to the Prograf. But I think there's a lot of emerging data to show that people who have chronic repeated episodes of hepatic encephalopathy prior to transplant may develop some chronic sequelae, and there's a move underfoot maybe to give some of these patients priority on the list pre-transplant. What we see here very often is patients with HCC start off with stable liver disease. They have their Child's A, and then they get repeated treatments of their HCC, and they start out as Child's A and they end up as Child C, and they have very difficult technical operations because of radiation changes. So this is another reason why we ask that these patients get into the system earlier. The list of absolute contraindications for liver transplant has decreased over the years. Obviously, significant cardiopulmonary dysfunction is an exclusion. Uncontrolled sepsis, occult infection. This is not so cut and dry when you have a lot of hospitalized patients going into transplant. I'll talk briefly about extrahepatic malignancies and why we're starting to think about transplanting some of these patients a little more frequently. Advanced AIDS is clearly an exclusion, but you don't really see patients with this anymore because of the wonderful therapies we have. Well-controlled HIV is not an issue, and I'll show you data later on in the talk about this. A lot of relative contraindications to transplant. Extensive portal vein thrombosis. The surgeons are great at bypassing these. However, if patients have an SMV thrombosis as well, they may need a multivisceral transplant. So the number of multivisceral transplants has increased slightly over years. I talked about extrahepatic cancers. We'll talk about alcoholic hepatitis and what has happened with this in the United States. And clearly, if people have HCC or cholangiocarcinoma, if they fall within specific criteria, patients do exceedingly well. But there are patients who have cancers who are outside guidelines. They may not do as well. They can be downsized into appropriate criteria. I think the most important thing is the experience and expertise of the transplant team. So we all know about MELD has been time tested now. Remember here that the creatinine carries the largest weight, followed by the INR and the bilirubin level. Your bilirubin may be 30 and your MELD score will be 28. So because of this, there are more and more combined liver kidney transplants performed. Because of the recognition that hyponatremia is such an important milestone in the natural history of liver disease, several years ago, UNOS adopted the MELD sodium score. Your typical hyponatremic patient who has a MELD score that does not reflect the severity of their liver disease has ascites, type 2 hepatorenal syndrome, and they're sarcopenic. So this is the chart that shows you how patients who are hyponatremic are given a priority on the waiting list, and they're given additional points. So for instance, if your natural MELD score is 18 and you have a sodium of less than 125, you get additional 9 points. So we've had this system for approximately the last 4 years here. Around 30 to 40% of liver transplants, patients have HCC as the primary or secondary indication for transplantation. This is an increasing problem with patients who have NASH. We all screen our patients biannually with imaging and AFP. Many transplant centers in the United States use cross-sectional abdominal imaging rather than ultrasonography, even though many societal guidelines recommend ultrasonography. Here in the United States, patients are often a lot bigger, and I think that is a problem. And the performance of ultrasonography, I think, is more of an art outside of the US than it has been established here to date. So we use cross-sectional abdominal imaging. These are the specific Milan criteria that we adhere to, which give people priority on the list. As I mentioned, we try to aggressively treat patients while on the waiting list. So what has more recently happened is that the recognition that AFP is important for these patients prognostically, we've come around to, and so patients have to have AFPs decreased to less than 500. If people have an AFP of greater than 1,000, they get no priority on the waiting list. So this is really important, and I would say is, since the DAAs, I believe that the importance of the AFP is become more important. As you recall, with active Hep C, the AFP could be 150 to 300 sometimes. But now, if you have patients who've been cured of hepatitis C, I would tell you that any even slight increase in AFP should raise concern about an early HCC. There's no standardization across centers for the use of immunotherapy and the timing outside of protocols. Here, we don't use immunotherapy unless patients have significant tumors or tumors that are going to push them outside of priority, tumors that are abutting the portal vein. So this has not become standard of care in treating all patients across waiting lists. Obviously, the timing is an issue because immunotherapy has been found, nivolumab, for instance, has been found to be associated with appreciable rejection rates after liver transplantation. So I think that one has to keep this in mind when transplanting patients, and I'm not saying not to use this in patients, but they come to transplant and they've recently received an immunotherapeutic agent, they should be followed closely for the development of rejection. We've seen some remarkable responses with the use of immunotherapy. I have 2 patients who had resolution of tumor thrombus, and one successfully got to liver transplantation. I mentioned the logjam at the MELD exception criteria. Here in New York, it's 28. So thus, I think there's an increased need to consider living-related donation. We're using more donation after cardiac death donors. Despite all of this, 10 to 15% of patients with HCC within Milan criteria can still develop recurrence post liver transplant. So I think we're all waiting for some of this very exciting work on looking at molecular biologic signatures to look for bad players in patients who have bad HCC in terms of their natural history, to sort of prioritize some patients for transplantation over others. The development of the DAAs really, I think, when we look back on this another 10, 15 years from now, we're going to look on this as being really a milestone in medicine overall. I mean, cure rates in well-compensated cirrhotics are close to 100% now, and we're not even having to use ribavirin anymore. Remarkably, there's equal success in co-infected patients. This was never the case. In some patients, you can have some issues with liver decompensation in the sicker patients. So early on, we were looking to transplant everyone liver transplant in an effort to maybe obviate the need for transplantation. This is sort of has changed However, because of treatment becoming so easy after transplant. So we're concerned in that some patients, if we treat them, their MELD score may decrease. Maybe they're going to get a little bit better clinically, but then they're going to be less likely to get a transplant. This has been termed as a MELD purgatory. I have a couple of patients who fall into this category that they had refractory ascites, they had MELD scores in the low to mid 20s. We treated them, we cured their Hep C. Now their MELD scores are in the high teens. They have a poor quality of life. They can't get transplanted. Is cirrhosis reversible in all patients? My own bias, and this is only my bias, is that if people have had clinical portal hypertension, they've had ascites, they've had varices, I think these are individuals that still may require transplantation one day and are still going to be at risk for HCC. So our dictum here is that all well-compensated cirrhotic patients should be treated and cured if they aren't on the liver transplant waiting list. So if people are on the liver transplant waiting list, we've moved away from treating them and are looking to treat them post-transplantation. I alluded to the fact that more and more patients who have HIV are being transplanted. In the US, the HOPE Act was passed in 2013 that now allows us to use HIV positive organs in HIV positive recipients. So what this has done is this actually has prioritized patients who have HIV on the waiting list. So if you have someone with HIV and they enroll into the HOPE Act, they can get transplanted with a very low MELD score. So this has increased their access to transplantation overall because the HIV positive organ is only going to go into an HIV positive recipient. So overall, we found that Sinai is one of about a dozen programs who are in the HOPE Act NIH-sponsored protocol. That patients who have HIV, typically they have Hep C concurrently. There's no increased risk of infectious complications. Rejection was previously problematic, but is less so with the new heart regimens. It does remain somewhat problematic on the kidney transplant side. 10 to 15 years ago, graft and patient survival rates were suboptimal, but this was because of Hep C recurrence, which is no longer an issue. So we expect that as time goes on, patients of HIV are going to continue to do exceedingly well post-liver transplantation, and they have an increased access to transplant services now. I alluded to the fact that post-transplant Hep C treatment is become very, I don't want to say easy, but less of a traumatic experience for the transplant hepatologist. It used to be really an issue. Cure rates are exceeding 95%. I can't recall the last patient we couldn't cure after transplant. We're not using ribavirin, just with 12 weeks of monotherapy. This has led to decreased need to retransplant patients who have Hep C recurrence. Again, I can't recall the last patient we've had a retransplant due to hepatitis C recurrence. I think this is opening the doors for more patients who have chronic allograft failure, rejection, irreversible biliary issues to be evaluated as candidates for retransplant. There's a lot of thought that this is treating and curing the hepatitis C is going to lower all-cause mortality, including decreasing the incidence of diabetes and renal dysfunction post-transplant. I think very importantly, achieving an SVR in these patients is going to allow us to more aggressively try to wean people off of immunosuppression and decrease all of the attendant adverse effects of the immunosuppressive agents. In the past, we were always afraid that, well, if we lowered the Prograf a little too much, maybe the patient would reject and we would have to give them steroids and the hepatitis C would flare. Now that we don't have to worry about that anymore, I think a lot of us will more aggressively try to wean people off of immunosuppression. We've talked about some of the transplant ramifications of the DAA. As I mentioned, more patients who have allograft failure are now being considered for retransplantation. Our transplant program started in 1988, and some patients who were transplanted early on for autoimmune hepatitis, for PSC, are now running into problems 30 years after a transplant and may be coming to retransplant, as well as patients who were transplanted as children and now have allograft fibrosis and allograft cirrhosis. These people are coming to retransplantation. And I think the biggest ramification of the DAAs has been the ability to use hepatitis C positive organs and hepatitis C negative recipients. So this is something that has been going on for the last, I would say, 5 to 7 years. And this is some data, as you could see, that the number of overdose deaths that has affected the United States over the last, I would say, 7 to 10 years has led to this. So the number of donors who have drug intoxication as a cause of death has dramatically risen. Those who are hep C positive, the percentages of hep C RNA positivity, all of it is increased. And these donors are actually younger, tragically. So these are suitable donors for transplantation, and the transplant community has tried to utilize them. I think that the number of overdose deaths really is, we're going to see down the road when we analyze what has happened to all of us during the COVID pandemic. This is one of the causes of deaths of despair, that term has been given. People who have had worsening of alcohol-related liver disease that we'll see, overdose deaths. So these are major issues that are resulting from the pandemic. So the use of hep C positive donors has quickly become standard of care. We offer this at our center. We offer this to every patient, whether they have hep C or not. The initial studies were in kidney transplant patients and achieved SVR rates of 100%. This initially led to dramatic decreases in waitlisting time for kidney transplant patients. Now it's no longer that much of a decrease because everyone is using these. We have 100% SVR rate in patients after liver transplant, and equal number after kidney transplant. So we thought that maybe getting the medication from the insurance company was going to be an issue, but it really has not proven to be the case. And again, data has shown 100% SVR rates in all solid organ transplants. So this has really changed the playing field for patients on the transplant waiting list. So this is an old slide, but I show it because it shows how long NASH has been a problem for us. So this was a review of the SRTR or UNOS database, and it was published in 2011 in gastroenterology. And up until then, you could see that hep C was stable, alcohol was stable, NASH was going up years ago, starting years ago. It hasn't been really a recent phenomenon. Autoimmune liver diseases, relatively stable. CC is cryptogenic cirrhosis, and you can see that this was decreasing. So that's because most of these patients had NASH. So I think very few people now are transplanted for cryptogenic cirrhosis. So NASH has been a problem, but is becoming more and more of an issue for us. Often these patients have clinical portal hypertension and brittle encephalopathy with very low MELD scores. Whether this is an issue with their microbiome, many of these patients have diabetes, and they're very difficult to treat because MELD scores, the only way they're going to achieve a high enough MELD score is if they develop renal failure. And then we're talking all of the morbidity that comes with developing renal failure. We are seeing an increasing number of patients who are developing HCC. Some recent data shows that immunotherapy may not be as effective in patients who have NASH as opposed to those who have viral hepatitis. All of these patients have medical comorbidities that are difficult to deal with leading up to the transplant and then post-transplant. Bariatric surgery is being attempted at some centers with, we have an interest in starting to try to use endoscopic balloon and endobariatrics for these patients. The Mayo Clinic has some very robust data. They're performing bariatric surgery gastric sleeves at the time of liver transplant in patients who have MELD scores in the low to mid 20s, and they're achieving good results. I think this is important because weight gain is universal post liver transplant. It's not unusual that patients would gain 20 pounds in the first year after transplant. So traditionally, for patients who have alcohol-related liver disease, they've had similar post-transplant survivals. The 6-month abstinence rule had been the norm, and everyone felt that this allowed spontaneous recovery and decreased recidivism. We asked people to go into relapse prevention programs. However, over time, I think the transplant community has reassessed this. Patients, we felt good about people going to relapse prevention programs, but if they really didn't develop insight and they went into the program, I'm not sure that they did any better than people who did not have 6 months of abstinence, but who had true insight into their liver disease. That is probably a better candidate than the other person. We have to be careful about screening these people for head and neck cancers. We've seen several of these recently. They're at risk for these, so they have to be screened both pre and post transplant. And we found that selected cases of alcoholic hepatitis do well post-transplant. This has very quickly, again, become commonplace and almost standard of care in the United States. This was predicated on, I think now we're sort of a landmark study by a Belgian-French group that was in the New England Journal of Medicine in 2000, termed the Matherin study. And they showed that if you select the patients well, they do exceedingly well with an acceptable risk of recidivism post-transplant. And don't transplant them, they're going to be they're going to have a very high mortality. This is data from our program. We were one of the first programs here in the U.S. to start doing this in 2012, and we put a lot of import into family support, the development of insight into the alcohol-related liver disease, and this has to be their first liver decompensating event. And you can see dramatic differences in survival in people who went into transplant and those who didn't. And we in other programs are not perfect with this. We've had a lot of people. We're approaching now 100 patients who have undergone early transplantation for alcoholic hepatitis. We're not perfect. We've had probably a 10% recidivism rate. 2 patients have returned to harmful drinking. But the thing to remember is that in the patients we evaluate, for instance, we only accept about 12% of patients that we evaluate. So I think that this is being done judiciously. We need better treatments medical treatments for people who have alcoholic hepatitis. A consortium of several centers looked at this, and they found similar results. Sustained alcohol use was infrequent, but when it did occur, it was associated with mortality. What we've also found recently is that we sort of have analyzed the cost and the significant hospital cost, because we have to transfer these very sick patients to our service. It's very labor intensive. Many of them, if they can't get transplanted, they succumb to their illness here. They're not dischargeable. So thankfully for us and the patients, the hospital has signed on and is very supportive of this. We need better outpatient addiction services overall, medical therapy of alcohol use, alcohol dependency. many patients, they're in the hospital, they get a little bit better, and then we send them out into the ether. And a lot of these people, if they didn't drink, they would be okay, but unfortunately they fall back and they drink again. A very interesting article is in this month's Hepatology from the University of Wisconsin. This is Musto et al. And they looked at their patients who were not accepted for early transplant. These are patients who had alcohol-related liver disease, and they found, and alcoholic hepatitis, and they found that 35% of patients actually improved. And that improvement occurred within the first week of the hospitalization. So these were patients who were not on steroids or had failed the corticosteroid treatment. So I think this is a really important point in trying to decide, can you wait on patients to get better, or do you have to get them into to transplant? They also found that patients who did get better and had spontaneous recovery, their MELD score dramatically, they still had issues with ascites and complications of portal hypertension, as you might expect, since many of them, the majority of them, probably have cirrhosis. So some of the lessons that we've learned during the pandemic is that we've and other centers, I think throughout the U.S., have been really overwhelmed with people who have decompensated alcohol-related liver disease, alcoholic hepatitis, ACLF, recidivism to alcohol. Here in New York, we have a major issue with people who are undocumented individuals who don't have insurance, who are presenting with liver decompensation, and we're sort of stuck. We're trying to get them insurance on a case-by-case basis, but it's really, really tough. As I alluded to, we need sort of a greater comfort level and more studies looking at the use of medications to promote sobriety and better treatments for alcoholic hepatitis. I would say at this point, maybe at least 75% of the transfers into our hospital from other centers are due to alcohol-related liver disease. And just as a side note, there's been an increased awareness of high burnout rates amongst transplant hepatologists and surgeons, and I think this has only increased during the pandemic. So what does the future hold for transplant programs? Well, xenotransplantation, stem cell therapy show very early promise, but are still years away. We've seen in the news some very recent exciting xenotransplant cases, both in kidney and in heart. I think that it's great. We remain hopeful. I think that there's still a lot of hurdles for this. So I think that we'll continue to do research in these areas, but I wouldn't guarantee that we're going to see this become standard of care, at least during my career. I think the new treatments for chronic liver disease really are important, and we remain very hopeful, especially for NASH. There are antifibrotics and alternative immunosuppressive medications being studied. I think that at this point, now that we don't have to worry about hepatitis C coming back and the graft survival from it, we're thinking about trying to extend the life of our patients with the grafts that they have. So if we can decrease the morbidity of the immunosuppressive medications, I think that things will be better overall for our patients. I don't anticipate that the total numbers of transplants will decrease. I think we will keep pushing the envelope, but I think we'll be able to hopefully save more lives with the organs that we have. Also allow us to push the envelope with other indications. For instance, alcoholic hepatitis. There's a lot of interest now in liver transplantation for patients who have colon cancer metastases. So what's very exciting is the use of normothermic and hypothermic perfusion systems. Many centers here in the United States are now using these. This was a research protocol, but it is past this now. This was a very interesting article that I would refer you to in the New England Journal last year. And this has been done on the kidney transplant side for decades. So this is allowing us to use maybe suboptimal livers, donation after cardiac, that's steatotic livers, and try to ensure that they will work in recipients. As you can see, still close to 10% of donor livers in the United States are unused, are discarded, and many of them is due to the fact that they have steatosis in them. And I think as our population is getting older and bigger and more NASH, I think this is going to be an ongoing issue that we have to deal with, and I think we're starting to deal with it with the use of pumps. There's a lot of interest in biomarkers and precision medicine, not only to diagnose rejection without a liver biopsy, but I think importantly to sort of understand levels of immunosuppression to allow us to maybe more aggressively take people down off of immunosuppression or wean people from immunosuppression, maybe even take some people off of immunosuppression in an effort to try to avoid the medical complications, the renal failure, the diabetes, the hypertension. The data is very sobering to know that 10 years after a liver transplant, 25% of people are going to need a kidney transplant or have end-stage renal disease in the United States, in large part due to the immunosuppressive medications that we give to patients. There are many ways we're exploring to increase liver transplant rates. There's a lot of forays using artificial intelligence to try to refine predictive analytics to match donor and recipients with minimal ischemic time. There's a broader use of older donors and DCDs. I think the perfusion systems are going to allow this. Most centers are now developing a greater expertise with using donation after cardiac death livers. I mentioned the need to really try to abrogate some of the disparities that occur in transplant, be they socioeconomic, racial, or gender-based. I mean, clearly, there have been data recently showing that women may have a higher mortality rate on the transplant waiting list. African Americans may have a greater mortality on the liver transplant waiting list. They may not get access to liver transplant services. So all of these things are necessary to work out as soon as possible. We're trying to push the awareness of live donor options. The number of LRDs are increasing in the United States, but I think that we need to do even better with that. There's now a national LRD exchange program that is starting this year, so that this has been going on the kidney side for a decade, where if your donor doesn't match you at your center because of size or blood type, there could be a paired exchange with someone at another center. This is not going to solve the problem. This is going to be only for a very select number of individuals, but we have to do as much as we can to promote living donor. We have to improve OPO performance. We have to make sure that all donors are considered, and that the families are offered to have their loved one give the gift of life. It's a very tough job to work in the OPO and to be a coordinator, but there are differences across the country, and we have to sort of improve OPO performance across all lines. We're considering the transplantation of a patient with certain malignancies. The old dictum was that, well, you have to be 5 years tumor free, because we didn't know the confounding effects of immunosuppression. But we realized that this wasn't always the case. A woman with stage 1 breast cancer, for instance, has a normal life expectancy. So why preclude them from transplantation? Is the patient going to die of liver disease, or will a transplant make them a better candidate for ongoing cancer therapy? I think these are questions that we can start asking now. We're thinking about, again, selected cases of patients who have colon cancer metastases. We've transplanted 2 of these patients now, 8 and 10 years respectively, are still doing well. Someone who has a melanoma 5 or 6 years ago that was a deep melanoma, they may never be a candidate for a liver transplant because of the concern of recurrence. And we think about this in selected cases of patients who have severe graft versus host disease. So again, I think that we've opened the doors to the consideration of other patients for liver transplantation. Some of the concerns that we have, however, are somewhat sobering. The increasing number of patients who have Fontan-associated liver disease and how to manage them. Every center is facing this dilemma with patients often in their 20s or 30s who had congenital heart disease, who had the Fontan procedure, and we're now to developing cirrhosis now 20, 25 years later. We don't really know what to do with these patients, how to manage them. Do they need a liver transplant alone? Do they need a combined transplant? They are at risk for developing HCC. So this is an issue that everyone is struggling with, and there are a lot of these patients out there. So we have to have, again, some consistency in trying to deal with them. I'm worried that the current donor shortage is going to worsen. Again, with the pandemic, this has not been an issue, but this is because there've been an excess of overdose deaths. I'm also worried that a lot of these wonderful medications that are being studied and touted for NASH may not help the cirrhotic patients. Maybe they're not going to help the people who've already decompensated. And this is a concern, because again, there are a lot of them out there, and they may all come to transplantation, unfortunately. The alcohol cases are continuing to increase. I think we need to have some ethical discussions about transplanting some of these patients, and I think there needs to be some implementation of some well-meaning guidelines in who to transplant and who not to. And as I mentioned, there's never increasing need for simultaneous liver kidney transplant, and I think this is only going to increase in the future. So in summary, the DAAs really have, the advent of the DAAs really have changed the playing field for liver transplant programs and our patients. The use of Hep C positive donors has become a standard of care very quickly in patients. The logistics and profile of the waiting list are ever changing as we think of extending indications to other patients and diseases. NASH has become a major public health issue, and all liver transplant programs are struggling to deal with it. And as always, ethical discussions have to always accompany innovations in anything, but especially in the field of liver transplantation. Thank you very much.